Good afternoon, everyone. Welcome to American University Washington College of Law. Thank you to everyone who is here joining us in person and those of you joining online. I'm Maya Manian, Faculty Director of the Health Law and Policy Program here at WCL. The Health Law and Policy Program, together with WCL's program on Gender Theory, Law, and Practice, are pleased to host today's event, which is Preventing Stillbirth, Legal, Policy, and Public Health Perspectives. We're so grateful for our partnership for today's event with the American Health Law Association, the nation's largest nonpartisan 501c3 educational organization devoted to legal issues in the healthcare field. AHLA maintains excellence in health law by educating and connecting the health law community. This event is also in partnership with the American Society of Law, Medicine, and Ethics, which is a nonprofit educational organization whose mission is to provide high-quality scholarship, debate, and critical thought for professionals at the intersection of law, medicine, and ethics. I want to especially thank the Health Law and Policy Programs Director, Asha Shelzo, who is serving as the immediate past president of AHLA and on the board of directors of ASLME. She continues to facilitate these important partnerships and ensure that our programming reaches a national audience. If you can bear with me, there's a few additional people here at WCL that I would like to thank. We have so many wonderful support staff here who work behind the scenes for many months in advance of these events to ensure that everything runs smoothly. So I want to give a special thanks to our catering department for nourishing us today, to our facilities for all the setup, our AV team, including Ryan Say, our special events team, including Courtney Watson, and our marketing team, including Keith Pierce, for helping us put on the event. And last but not least, I want to thank our Health Law and Policy Program Coordinator, Tamina Asif, who, as always, goes above and beyond in coordinating all aspects of this event. I have a few administrative notes. Please note that live captioning is available. This event is being recorded, and the recording will be made available on the Health Law and Policy Program's Future of Healthcare series website. So today's program is part of our Future of Healthcare series. This series features panel discussions that examine trends, challenges, and opportunities in healthcare and the role of law and policy in shaping our healthcare system. We highlight both practitioner and scholar perspectives on a wide range of timely topics. This is now our third year of the series, and we are delighted to have reached over 1,000 attendees nationally and across industry sectors with this series. So our event today will explore the often overlooked public health crisis of stillbirth in the United States, which affects approximately 1 in 170 births each year. Drawing on insights from law, health economics, and public health, our distinguished experts will examine how legal frameworks shape prevention efforts, parental experiences with stillbirth, and broader debates about reproductive health care that continue to go on intensely in our post-Dobbs public health landscape. Many thanks to our distinguished speakers today for making the journey to DC and for sharing their insights with us. I am also especially grateful to Associate Professor of Law, Thomas Williams, who will be moderating our panel discussion. Thank you, Professor Williams, for your leadership and your contributions to this event. So I'll now turn it over to Professor Williams to introduce our panelists and kick off our discussion. Thank you all so much.
Thank you, Maya. Good afternoon. Welcome. Today's Future of Health Series program. As you know, our esteemed panelists and I will be talking about this question of preventing stillbirth and considering the legal policy and public health perspectives of that framing. Before we get started with the discussion, I just want to echo all the thanks. This doesn't happen with all of the support through faculty and staff, so thank you. We do have a good amount of time today, which is exciting. I'm grateful for it because I know that we will also run out. There's just so much to say. We had a really wonderful pre-call and just all kinds of ideas were flowing. It was wonderful. But before we get started on that conversation, I just want to make sure that everyone in the room has a shared baseline understanding of stillbirth. Because honestly, until I met Professor Jill Weberlings, who I will introduce shortly, I hadn't really thought about it. I will say that we all have room to grow, and I want to invite the room to enter this conversation with some shared vulnerability, because the gap in knowledge around stillbirth is for many of us shared. Undertaking to correct it is a shared endeavor, which we will do a lot of work on today. The national conversation on women's health for at least the last several years has arguably been singularly focused on questions of abortion rights and access, and for good reason. This panel provides us an opportunity to leave today's conversation with a broader understanding of the continuum of women's health, which should include meaningful dialogue around access to contraception, questions of the appropriateness of and access to sterilization, miscarriage, access to assisted reproductive technology, but also accessibility that folks have to whole women's care, basic women's health care more generally. It should also include robust discussion of stillbirth, an attempt to better align law with theories including reproductive justice and health justice, and with the lived experiences of the women and families experiencing stillbirth. This includes understanding the relevance of social determinants of health and considering newer fields of research regarding patient-provider concordance. This is the idea that shared or mismatched identity vis-a-vis providers, which includes mismatch on race, might have consequences related to delivery of care and health outcomes. Stillbirth, as Professor Mania noted, lives in the shadows of our broader women's health dialogue. And the law, I would say, lives in a shadow of that shadow, operating to obfuscate our understanding of stillbirth and its causes. This panel, again, is an effort to shed more light on it from this interdisciplinary lens. A note on language: I will do my best to clarify any terms of art or unfamiliar language that is used during our conversation, but alas, I am a law professor and may miss some. Please feel free to raise any questions in the chat, or to raise your hand if there is, as I tell my students, a burning question that inhibits your understanding of what we're talking about. To get out front of that, I want to just briefly describe the theory of reproductive justice that I mentioned previously. Reproductive justice is a framework that connects reproductive rights with broader social justice issues, asserting the right to bodily autonomy, the right to have or not have children, and the right to parent children in a safe and healthy environment. The term was coined by a group of Black women in 1994, and the movement recognizes that individual reproductive choices are deeply impacted by economic, racial, and social inequities. Now, just a little bit about the topic at hand, and panelists, I'll say please feel free to correct me, especially when we talk about data, because that is a live question that you may not be aware of, but I'll give you a little bit about. So to start, the CDC defines stillbirth as fetal death occurring at any time after 20 weeks of gestation, but before birth. It's further broken down by the CDC into 3 distinct groups: early stillbirths, which occur between 20 and 27 weeks, late stillbirths occurring between 28 and 36 weeks, and term stillbirth, which is any point after 37 weeks. Now, I want to give you some data, but as I just alluded, I have to kind of talk out of both sides of my mouth to do it. There are a lot of questions related to stillbirth data that I promise you we will talk about, but you also need some data points to get a sense of the size of the problem. A recent review of 2.8 million pregnancies in the United States from 2016 to 2022 and reported on by the Washington Post earlier this week, or perhaps last week, revealed 19,000 stillbirths in that group and during that period. From that study, the researchers concluded that 21,000 stillbirths occur in the United States on an annual basis. And this study contradicts official CDC numbers that reported a lower instance of stillbirths in the country, and amounts to 1 in 150 pregnancies in the United States versus 1 in 175 that CDC data indicated. For Black women, the rate is 1 in 95. And I say for Black women, but what I'll allude to is communities with a high concentration of African Americans. For low-income areas, the numbers look like 1 in 112. For Native communities, this is 1 in 139. And for comparison, consider the rates for white women, 1 in 223, for Asian women, 1 in 270. Data from that study showed that just under 30% of those stillbirths did not occur in pregnancies with known health or clinical risk factors associated with stillbirth. I will skip this because I already noted it. I will conclude and shift into the questions and conversation that there are just huge gaps in our knowledge about the data that correlates or predicts stillbirth. And I think that we should also bear in mind that experts agree that a large number of stillbirths are preventable. This tracks with expert agreement that high rates of maternal and infant mortality are also preventable, and yet here we are. So for the first question, I will actually give you all the question and then introduce you and kind of go down the line to get your responses. For many members of the audience, stillbirth will be a new area of consideration. In the interest of time, I'll give very brief introductions, but I encourage you to look at the full bios of our panelists. And we'll ask in turn that you share with me and the audience a bit more about your connection to and/or point of entrance into this work and how that frames your thinking about the issues stillbirth presents. Please feel free to take 5 or so minutes to answer this question. It will create some of the depth necessary for us to bring the audience along in the broader conversation over the next hour or so. And I will, just so you know, be utilizing a very non-aggressive timer to remind you should you go over just a bit. I'll start with Dr. Cohen to my left. She is a professor of health economics at Harvard's T.H. Chan School of Public Health, where she focuses on health policy, behavioral economics, and maternal and child health. Her research examines how health systems, policies, and programs influence maternal and newborn health in the US and East Africa, with the aim of embedding this evidence into policy design and increasing policy impact. Dr. Cohen.
Excellent, thank you. Do I need to speak into this?
I think you're good.
Okay, excellent. Thank you all for coming. Thank you for having me. It's really an honor to be here. And honestly, more of a selfish act on my part. I'm here because I want to learn from you what the law and legal scholars can tell us, economists and evaluation experts, what to be looking for and how to think more broadly about the determinants of adverse health outcomes like stillbirth. Thank you also for coming to talk about this hard topic. So let's see, why am I here? Well, so first of all, I'm a woman who had high-risk pregnancies, multiple high-risk pregnancies, and had the sort of immense privilege of navigating those pregnancies with the benefit of my socioeconomic status and also the very high-quality healthcare that I received in Boston-based hospitals. But my entry point to this question, I don't think I'll spend a lot of time talking about the research I've done before and specifically how that got me to this question. I'll tell you more about how an economist thinks about these issues, this stillbirth and maternal health more broadly. So yeah, my trainee's in economics. I have a PhD in economics, but I sit at a public health school. So I'm sort of at the intersection of medicine and public health and economics and psychology. I try to use insights from economics to improve maternal and child health and well-being, both in the US and in low and middle income countries. I also work in Kenya, Uganda, Tanzania, some projects in Ghana. And I work on many topics in this space, but I'm very passionate about stillbirth because I think there is just so much more that could be done, and that the fact that it is highly preventable has not been attended to. So you're probably saying, when I say economist, you think about money. That's my guess, because everybody asks me, can I join their study and do cost effectiveness analyses? But actually, I don't know how to do cost effectiveness. Sorry if there are people listening on Zoom that want me to join their project and do a cost effectiveness analysis, but I'm not good at that. And I don't do very much with money, although I will say that we have done and are currently doing some work on the very high out-of-pocket costs of maternity care for commercially insured individuals in the US, and it is a very serious problem. Hopefully we'll come back to that. But really what I was drawn to in economics, even as a college student in a liberal arts school, was this very helpful framework for understanding how people make decisions and how they make decisions, and how behavior manifests in structures that have different incentives and information and norms, and so, when I think about stillbirth prevention and how we can do more, I like to really get in the weeds of how are doctors deciding who should be screened and who shouldn't? How are patients deciding whether they should call the doctor or their nurse, if they're feeling something might be wrong or could be wrong, right? And the obvious parts of that are, do you have co-insurance or a copay, or how far do you have to drive for care? But there's much more involved in how those decisions get made. And a lot of it is about the health system structure, how payers reimburse for maternity care, Medicaid reimbursement for maternity care, how health systems are designed to reward innovation or not. And so I sort of like economics because it helps me think about those decisions. And it also, at its core, is really about scarcity and how we allocate scarce resources. And so one of those scarce resources is money. So how does our health system or how does the government allocate funding across priorities? But it's also about how people allocate attention, which is a scarce resource, right? And so thinking about, again, back to this question of, for example, prenatal screening or C-sections or other decisions that get made, what is directing healthcare teams' attention to certain patients and not others. So that's sort of the flavor. The only other thing I'll mention, I guess, is that economics gives us a nice framework for looking at rigorously measuring impact. So how does this change? This change in the law, this change in reimbursement policy, this change in the way we remind people of things through an electronic health record system translate into actual behavior change and impact. So I do a lot of work in randomized trials, in non-randomized quasi-experimental methods. And so this is just a plug for what economics can do to help you understand these problems beyond counting coins.
Awesome. Thank you so much. Right. There's a great correlation causation conversation to have at some point. Wonderful. And I'll just say thank you to the students too, because I know where you are in the semester. So it matters a lot that you guys have taken time to do this. Well under time, Dr. Cohen.
You get to hear the gentle alert.
It's very gentle.
Okay.
Right, not existent. All right. Dr. Catherine Gold is a board-certified family medicine physician at the University of Michigan Health, the alma mater of Professor Manion, who is she's go blue. She has joint appointments in family medicine and OBGYN, or obstetrics and gynecology. She holds a master's degree in social work, which I think is really important for us to consider during this conversation, and a master's in health and health services research. She completed a fellowship through the National Academy of Medicine in 2016, and she has previously served as chair of the International Stillbirth Alliance. Dr. Gould?
Thank you. Thanks for inviting me. I will say I have a little nervousness being around so many lawyers and law students here as a physician. About things from a really practical. And so I'm a doctor. I was almost 9 months pregnant when I was walking across the stage at my medical school graduation. In fact, I joked to everybody around me, like, if they talk too long, I'm just going to pretend I'm in labor and start like letting out groans. And 3 weeks later, my baby stopped moving and I went to the hospital and the baby was dead. And that for me set off a whole series of events that affected what I did with my life. It affected what research I did. It affected what I cared about. I sat in support groups with other families and I listened to them share their stories. And I thought, well, what's the data say? What's the best thing that we can do for families? What's the best care? What's the rate of maternal mental illness after something like this happened? And I just got really interested in the numbers. And what I learned is there were no numbers at that time. The only studies that were out there were really small qualitative studies where you got like 10 bereaved parents in a room and you asked them about their experience, which has some value, but it means there was a lot of stuff that was missing. So now what I do is I do general family medicine. I also run a free clinic in Detroit where we do free prenatal and infant care, which for me is about as close as I can get to helping prevent stillbirths on a day-to-day basis. And I do research in this area. The practical thing I want to get to, because many of you look like you're young, you may or may not have children. Some of you might have children. If you haven't had kids, you may not know a lot about pregnancy. I certainly did not know about pregnancy before I had kids. So can anyone tell me how many weeks, like if I give you your due date is October 10, how many weeks pregnant is that? Because we're talking about weeks here. Does anybody know that? Yeah.
40.
40 weeks. Okay. So stillbirth is after 20 weeks, right? So that's the second half of pregnancy. And miscarriage is in the first half. And you also hear a lot about infant deaths, which they can be any time in the first year of life, but most of the time they're in that first month of life, very quickly after baby is born. So I think it's helpful to know that. Does anyone know approximately when the person carrying the pregnancy can feel the baby move?
Roughly 16 weeks, sometimes a little earlier or later, depending on what it is.
Yeah, that's pretty close. I would say for a first-time mom, probably closer to 20 weeks, but it's about that halfway point, right? It can be earlier if you've been through this before. So when we're talking about stillbirth, we're talking about pregnancies where people are just starting to feel that baby inside, right? And it's any time after that. And you can imagine I can imagine any of you, if you found out you had a positive pregnancy test right now, you are starting to think forward about, what am I going to do? What is this going to look like if I'm going to have this baby? Oh my gosh, when is this kid going to be in kindergarten? Like you're already planning things because we know that people attach to their pregnancies as soon as they get that positive test. And what we think is that the farther you've kind of moved along, like when you move to the second half of pregnancy or a very early infant death, the impact of having that baby die typically suddenly is extremely traumatic in most cases. There's no warning. When I think about deaths, about a third of deaths are sudden and unexpected. So you can have the death where like your grandmother's been very sick for a long time and you get the news that she's passed away and you've had some time to anticipate like this bad thing is going to happen. But on these kinds of deaths, typically everything is fine until suddenly it isn't. So I see somebody in my office and there's no heart tones for that baby. Or I see somebody in triage and that baby has died. And it just goes like from 0 to 100 overnight. So these are powerful events for families. And I just want to put it in that clinical perspective, because I think if you don't work in that perspective every day, you can kind of forget what it means clinically to these families who have this happen. All this stuff.
Okay, wow, you guys are lots of time for questions. I love it. I also just want to kind of reify what you've said about like we rely on data, and I introduced this with data and I skipped some of my notes, but one of the things I wanted to say is that I think we should all reflect, and I think this has to happen in 1L classrooms, it has to happen in public health classrooms, that these are individual stories that impact families in profound ways that data cannot capture, or at least chooses not to right now. And so thank you for bringing us back to understand that lived experience as part of this conversation. Last but not least, my fellow lawyer. Professor Jill Weber-Lenz is the Dorothy M. Wiley Professor in Excellence at the University of Iowa Law School. She is also the author of Stillbirth and the Law, which was published by University of California Press. I won't say much more, but we'll say the floor is yours.
Sorry, I'm just like calculating if I want to go really long because I want to see how aggressive.
The gentleman.
Yeah. We can get Socratic.
Sorry, that's okay. How I got here, it's a pretty easy answer. Of my kid is how I got here. It was my third pregnancy. We have 2 girls already. It was my third pregnancy. It was the boy, right? It was kind of the reason we tried for a third time. As we got the boy, and I literally have written in my notes, Katie, everything was fine until it wasn't. Right? Everything was fine until it wasn't. I guess I should say I did have gestational diabetes, which does increase the risk of stillbirth. Not that anyone told me that at the time. But so I guess in that sense, maybe everything wasn't perfect, but I was so mad I couldn't have carbs. I love carbs. But I was doing fine with diet. Okay, so that it wasn't like it was out of control gestational diabetes by any means. And I had one of those term stillbirths. I was 37 weeks. So we were 2 weeks out from when we were going to induce. I wanted induction at 39 weeks, which is it's standard for later babies after your first. I was 37 weeks. It was one night, I was really uncomfortable. I wasn't in pain. I was really uncomfortable. Now I look back and he used to stick his butt in my rib really hard. And it was just felt like that sort of constantly. But it wasn't hurt. I didn't hurt though. So I went back to bed, got back up later, and it was the same. And then we went to labor and delivery, not because I was worried, but just because my brother was in town. So we had childcare essentially is why we're like, yeah, we might as well go to labor and delivery. And they couldn't find his heartbeat, right? From like the very beginning, they couldn't find his heartbeat. I was later, so it was like the middle of the night. I think in the morning I was told it was a placental abruption, which means that the uterus just detached. I'm saying that wrong, aren't I, Dr. Katie? Pretty close. It just detaches from the placenta. So like he didn't have any more the nutrients and oxygen and everything. I will say I was told a couple later you didn't have a placental abruption, which was a very fun thing that just made me conclude that doctors don't know what they're talking about. So that's reality. A fun thing about stillbirth that also people don't appreciate is that the baby has to come out. Right? Caleb was 6 pounds. Baby has to come out. I was actually I appreciate this so much going back now. My doctor offered to do a C-section so that I wouldn't have to give birth vaginally. I did not want that though, because I didn't want this huge surgery on top of everything else and the recovery that would come from that. So yeah, I gave birth naturally. It was also my first no epidural birth, but my doctor also gave me some drugs. So I was actually kind of asleep, which I still think back, it's just amazing your body can do that. Like there was no mental physical connection. So I gave birth to him and we spent time with him the next day, and it was of course the saddest day of my life, but it was also one of the happiest days of my life because I got to be with him. And eventually I started to adjust to this new life of being a parent without the kid there. I was also already a law professor at this point. He was 2017. So I've been a law professor for 6 or 7 years at that point. And I got back to work and everything I used to do seemed so trivial. I found myself Googling stillbirth a lot, to the point I asked my therapist, is this okay? And she said, it seems great actually for your personality. So thank you. Thank you to my therapist. And I started thinking about everything law and stillbirth and hitting pregnancy loss more generally also. And at first I was like, I don't really actually think there's a lot to talk about here. And then it became very clear that there was a lot to talk about. And I have to give a shout out to Maya, because I don't know if you remember Maya, but like the first stillbirth paper I wrote, like a law review article, I definitely sent it to Maya for comments. Do you remember that? Okay. So I've had so many very helpful colleagues along the way, and I've just started talking about stillbirth from a legal perspective. And I think it's really, I mean, I get things more, right? Like, so I understand, I had a fetal death certificate, and like when I think about the impacts of how laws work, like I had that personal experience, except at the same time, oh my goodness, I know how privileged my experience was. My goodness, I know how privileged my experience was. And part of that though also reinforces to me that like I want everyone to have if stillbirth is gonna have to happen, I want everyone to have the experience that I did with it. Right. So I want to just be very careful. Like, I mean, ultimately, this is not about me. I'm not going to have another baby, much less a stillborn one. Right. So it's not about me. But I do think I'm quite educated in the actual experience of stillbirth. So yeah, I think that's my answer. Am I time-wise?
This is a very good class.
Okay.
No, this was wonderful and leaves more room, but I want to thank you, Dr. Gold, and thank you, Jill. It's so funny how I will always call you doctor. Thank
I'm
you
not
for
writing you a script.
But to thank you for like the vulnerability required to share those stories, right? But also as an example for our students that their lived experiences are worthy of inquiry, from legal perspectives and otherwise. So why don't we move on? This is, of course, really helpful. I think it frames things for our audience. There's a lot of threads here. But the data related to this issue presents both a microcosm of the problems in the relationship between American healthcare and scientific research, but it also reiterates the failure to meet women's basic healthcare needs across the board, especially for marginalized women. I'm not an economist, but it sure looks like a market failure. With that in mind, can each of you talk to me a little bit more about the role of data in this conversation and how it perhaps might connect to larger problems related to health equity and gender equity? And maybe you can add to this conversation a question about what you would like data to reveal that is not being asked, which you think is central to our conversation. And feel
To start, should I just give the background on how law legally?
Yeah,
we
go for
get
it.
The data.
Because I think too, like
Yeah.
some students would say data is not law, but I
It
think if you're a
is.
public health person or a person who thinks about solutions, it's got to be part of it.
It is actually the law is what actually gives us data on stillbirth. The main source of data on stillbirth in this country comes from something called fetal death certificates. Right, so if your baby's born alive, you get a birth certificate. If your baby is stillborn, so again, this is like 20 weeks to 40 weeks. If your baby's stillborn, what happens is the state issues a fetal death certificate. And the reason the state does it instead of the feds is actually all vital statistics are state, right? So this goes back along, like the colonies are what started doing vital statistics. And then when we were no longer colonies and we were, fed and state government, states kept with doing vital statistics. So the feds don't actually have any constitutional authority to do anything with respect to vital statistics. So it's left to the states. What does that immediately create the possibility of is some non-uniformity, right? So the state will pass a law about when a fetal death certificate has to be issued. And unfortunately, not all of our states actually use the definition of stillbirth. Some states very much do this right and say fetal death certificate issued if the baby as fetal death is after 20 weeks. But a lot of states are still stuck on a weight requirement. And they'll say issue the fetal death certificate if the baby's 350 grams. And if not 350 grams, if weight is unknown, then use the 20 weeks. Right, so that automatically is going to miss some smaller stillborn babies. Right, I don't know why. I don't know where that came from. I will say it makes me very frustrated. These are state laws, right? So there's no federal law in it. There is a model act though, like, hey, states, maybe follow this model act. And even the model act has the weight first, then weeks, which is very frustrating. All right, the reason we have fetal death certificate, the reason we have data is because fetal death certificates. And the reason fetal death certificates are issued is because the state law says that they have to be issued. One other thing I'll say on this is there are a couple states that do before 20 weeks. Pennsylvania is one of those. Arkansas is one also. Pennsylvania does 16 weeks. I bring that up because it's very helpful as far as capturing some of the earlier stillbirths, right? If it's just a 20-week, actually, if you were to say it at 16 weeks, it's a better chance that the early stillbirths are actually going to get caught as opposed to the 20 weeks. There's a lot of problems with fetal death certificates, though. And we have underreporting, and y'all would be shocked at the amount of data that's just missing, right? Like the fetal weight is just blank, right? And you would be surprised at the amount, well, maybe you wouldn't be surprised actually at the amount of inaccurate stuff that's on there. Maybe the weight is there, but it's just wrong, right? So there's been studies showing that like the chances of missing information and the chances of inaccurate information are much higher on a fetal death certificate than they are on a live birth certificate. And I think I'm going to pause there and let others jump in.
Wonderful, thanks so much. I just want to add, just from your book and from my understanding, that the part, and you noted this about the placental abruption, that the cause of death also seems to be often lacking, and maybe we can get back there or misunderstood more generally.
Sorry, sometimes the cause of death will just say stillbirth. And I'm like, wait, so death is the cause of death? Thank you. That's really helpful.
Like a tautology, right? Yeah.
Theoretically.
Okay, who, now the gauntlet is thrown.
I
Who
would
would like
just
to-
add a different angle. I was sort of like Jill in that I picked up her book and I thought, how can you write a book about stillbirth and the laws? There's no laws about stillbirth. And I started reading and I thought, oh, I never, as a doctor, I never thought about the fact that laws govern how we collect data and laws govern vital statistics and laws govern training and, you know, who does what. And so for me, as a non-legal person, it was a really interesting thing. I actually highly recommend her book. It's very readable, even for a doctor. Read it. I just want to point out what I found was I got very interested in health disparities and particularly around what happens to families afterwards. And so we know in this country, African American women are twice as likely, and in some places like Detroit where I work, 3 times as likely to have a stillbirth, but most of the research is on white, well-educated women. And when, you know, you think back to when I was starting and I was like, there are all these studies that are like 10 people sitting around and having a discussion about their experience. Those were almost always white, well-educated women. And so there has continued to be disparities on who we're doing research on and whose experience we're looking at. And that's an area that we continue to need to address because we need to be looking at the groups who are most experiencing this and getting their experiences and their outcomes. And that's not kind of where the research has focused over time.
Jill, you didn't give us your question. What do you want to know?
Oh my goodness. Can Jess speak in the middle while I start
Sure.
and think about my question? Sorry to figure this out.
No, you're great. I could talk for hours about data. You're in good hands. Okay, where to begin? So it's really hard to underemphasize from a research perspective how impactful it is to not have these fetal death data the way we have birth certificate or infant death data. This is one of the reasons I went into this research because it really, as a person who worked in maternal and reproductive health and have done it for years, it blew my mind how infrequently stillbirth was like on the outcome side of the analysis. You guys know what I mean? So there's so much research in health policy and health economics and law that looks at, I mean, everything you can think of, like the closure of maternity facilities in rural areas, the expansion of Medicaid, expansion of doulas. I mean, you could go on and on and on. And the outcomes are severe maternal morbidity or preterm birth, and I'm not making one thing less important than the other, but just to highlight that stillbirth is typically not looked at as the outcome of what happens when we expand Medicaid, what happens when we change admissions laws for, you know, when we regionalize healthcare. And, you know, part of that is because it's not seen as preventable, which we'll come to, but a big part of it is because the data is not at our fingertips the way that birth certificate data is. And so coming back to the behavioral economics piece, like one thing I've learned over time is that small roadblocks can introduce big barriers to behaviors, and it's not easy to put fetal death data together from this mishmash of different definitions across states and different variables, and things are missing. And so there's just blinders in a lot of cases in research. The other thing I'll point out though is that there are other sources of data that can be leveraged. So in this recent paper in JAMA that we put out that updated sort of our prevalence estimates of stillbirth pretty substantially, that used commercial claims data, right? So health insurance claims data is a really rich source of information for all kinds of health outcomes, including stillbirth. And there are really interesting overlaps with law. So for example, all payer claims databases are databases that different states put together with all payers, and often people who are uninsured, their claims go into that system too, and different state laws regulate who has to report into those claims databases. But you know, there are you know, many more types of data that we could tap to get at this question, but because it's not curated for us, it's really hard to put it together. Medicaid data is another example. Putting together a panel of live deliveries, let alone stillbirth in Medicaid claims data can take years. And so it's just been made, it's very, very hard. Oh, to your equity, I think your question about equity, I think, we can't improve what we don't measure. And so now we have documented over and over again in many cases in this recent paper, as you said, the disparities across areas that were zip codes that were predominantly African American women versus predominantly women had gigantic differences in stillbirth prevalence, like on the par with differences in being a high risk individual and not. But we don't have solid evidence about the drivers. We have lots of theories and associations, but we can't make it better until we have like a solid case for how to prevent it.
Underlying causes or things that are correlated.
Exactly.
Okay.
And I think a really practical example of that is a college-educated Black woman is more likely to have stillbirth significantly than a high school educated white woman.
Which, I mean, that ties back to like John Henryism, like weathering.
There's and we still don't well understand what's causing that. And that's a big issue that we need to.
And I'm sorry, because I did the thing. John Henryism is a theory about kind of stress on the body. Weathering is similar, but weathering you've heard more about, as you've heard about high rates of maternal mortality among Black women that just don't seem to make sense. One factor being that even high SES, well-educated Black women are still subject to the same trends. You're on call.
I did just get called on it because of my joke before, isn't it? I was just thinking when Jess was speaking too, I was just thinking also about like studies on COVID infection and stillbirth. And again, like we struggle with data on this. And part of why we struggle with data is like there's not a COVID question on fetal death certificates. And the CDC did put out a study on this about an increased risk of stillbirth from COVID infection, but they had to use other data, right? Like they had to use data from the hospital, which then only covered someone who had COVID at the time of delivery, as opposed to someone who had COVID earlier in pregnancy. So it's just like we're missing, like we can't figure these things out because we're missing the data.
It's almost like we don't even know what questions to ask because the data is so sparse that you guys can't give me a single question.
Yes.
And I think understanding if I take care of someone who has a stillbirth, I'm the one who's filling out that paperwork for the fetal death certificate. But let's say this baby comes out and looks fine and the mom's healthy. I'm like, I don't think diabetes would have caused it. I don't really have a reason. I'm going to put whatever I can come up with on this certificate for now with the thought, I'll go back later. If there's an autopsy, if we look at, in the lab at the placenta, once we get an answer, we'll go back and update that. But can you imagine how often that happens?
Especially when there's no push for the data to be reported, right? By insurance companies, by any of these actors.
So maybe I said, oh, it's probably gestational diabetes. I'm just going to write that down for now.
While I was writing, I've actually become extremely sympathetic for doctors that we ask them to fill out the cause of death on the fetal death certificate. You're not trained for that, right? It's amazing.
And we don't have all the data.
You don't have all the data, and you bring up autopsies. We don't have enough fetal autopsies in this country. Like if they're just not. It's a tough thing to talk about with a patient right after their baby dies. They cost money and aren't necessarily covered by insurance. But even if an autopsy is done, the fetal death certificate cracks me up because there is a spot to check, like if a fetal autopsy is expected or planned. I forget the exact words. So like you indicate on there, but then there's rarely ever amendment afterwards. And part of why there's rarely amendment afterwards is this pain in the butt. It's a legal document. So you have to initiate a legal process. And if it's something changing medical information, it's got to come from the doctor. Right. And people just have moved on. Right. It's also kind of awkward because you're asking your doctor, hey, remember what you said, why my baby died? You were wrong. Can you fix this? Like, so that's sort of an awkward thing. We don't get these things amended. I told the story of Anna Vick in the book. I mean, she has been on a mission for years to change her kid's fetal death certificate, and she can't get it done because the original doctor won't do it. And they send her the health department, and it's just, And it's just, and it's just principle at this point. But it's really frustrating. And that also sort of, the question, Thomas, I came up with is, I've been really curious also to think about how the parts of the fetal death certificate might be communicated to the parent. Because I've talked with some stillbirth parents, like in random states, and they're like, what are you talking about? I never got a fetal death certificate. Right. And like, I was mailed half of Caleb's in Texas. So I saw what, the cause of death was registered for. Anna Vick, who I mentioned before, she never got anything. I was like, well, what does the cause of death say now? She's like, what do you mean? I'm like, didn't they send you something? Right. So those are more state variations. And I would love to learn more about how much parents are actually learning in different states, because I think there's a big disparity there.
That's like really helpful. I think it's a nice lead in to like the next question. But that's also just like fascinating as I think about, there's always in my head, I always want to teach a death law seminar. And death is such a highly administrative engagement while you're in the midst of grief. And this is I'm going to say a kind of grief that's different in kind than like a loss of a parent. So figuring out how to, right? And so here we see the law as both the instrument that creates requirements and provides us data, but also handcuffs on the construction of that data and on its improvement. So part of my own scholarly agenda is to think about the role of popular culture in defining our experience of the world, and how and if that should impact a legal analysis of public health problems. I teach this class called Pandemics in Popular Culture. In our conversation preparing for this session, each of us noted that stillbirth has not had a cultural moment of clarity like that we have seen regarding miscarriage in the last decade, right? This idea that like people are going to talk about it, it's going to be open. I have a very close friend who I met for dinner from law school. We hadn't heard from her for months, and it turns out that she had lost her child. And then not sharing it, it may not be about shame, but feels connected to something in our cultural experience about what we can and cannot share. I guess I wonder why you think that is, and how might honest portrayals of stillbirth in popular culture shift the construction of stillbirth, either legally or otherwise. And your comment about even knowing that there's a fetal death certificate, the idea that folks might see these stories and understand the process is one thing that comes to mind. But how else do you think it might shift things? Because Jill, even in your story, you say everything was fine until it wasn't, and there was nothing in your construct of the world that gave you the information you needed to navigate that.
Yeah, I did. I emailed my assistant that I had had a miscarriage. I only learned later that wasn't the right word. Right? You don't know about that. It's strange, Thomas, to think about like better cultural portrayals, because like the last thing I want is for like a celebrity to have a still. Like I don't want anyone to have a stillborn.
Right. Yeah.
And I
would say don't leave out storytelling.
Yes. Well, storytelling is so, and you think about that with abortion too. I was thinking there have been some higher profile ones if you think about it. But also there's just like there's not a lot of information out there. I'm not the only one who follows celebrity gossip, right? People are gonna know who I.
The shame.
Not shame. Chrissy Teigen was a very high profile. I still remember just bawling that morning when I heard those.
And the photos, right?
The photos were the most gorgeous thing. And it was. I mean, it's not like this matters, but she was like right at 20 weeks, but all the headlines said miscarriage. And I was like, are we sure about that? And not. I mean, none of these are good examples, but if y'all remember Brittany Watts in Ohio, who was arrested after the cops felt the need to get the fetus out of the toilet. Overwhelmingly reported as a miscarriage. I was like, y'all, she was 22 weeks. Right. Again, that's not the point at all, but it was just more examples of like, I don't think people even know.
Lack of understanding of even what the thing is.
And let's be honest, the difference between a 19-week miscarriage and a 20-week stillbirth is arbitrary. Like,
it's a legal definition. It's a legal one.
I mean, it means something legally, it means something medically. Does it mean something different about the experience? No. Right, but some of the higher profile examples aren't even right. And of course, actually, Chrissy Teigen she had an abortion and just didn't realize it. Right. So we do have examples, but we don't actually even know.
Cause yeah, the Chrissy Teigen story, it occurred to me when you said celebrity culture, right? And I was like, oh, but in my mind, that was a miscarriage. And I was trying to figure out where in the timeline she was.
I mean, we don't know for sure, and again, it doesn't matter, that's not the
Yeah.
point, but everyone very quickly, the headlines were miscarriage.
Yeah, I mean, it raises this question about like you guys, if you take classes like contracts, or turns out you do, right?
That is required.
Right, yeah. But right, definitions are a critical like piece of this conversation, right? And what you call things. So it does matter. Dr. Gold, Dr. Cohen?
I'm thinking about a patient I actually cared for. She came into triage when she was a patient I had taken care of at my Detroit clinic, and she came into our U of M triage, active labor, had kids before. So usually once you've had your first baby, things go faster after that, right? So comes in, rip roaring labor, 8 centimeters, which is like, get her to a room really fast so she doesn't deliver right here. And they couldn't find the baby's heart tones. And they brought in a couple of doctors, the ultrasound on, and this baby had died at full term. And they explained all this to the patient. I heard about it. I went into the hospital immediately. I got there right before she started pushing. She pushes for 10 minutes, doesn't have an epidural. Baby comes out. And you know, when a baby is born stillborn, they're very floppy. They tend to be warm because mom's been warm, but the coloring is off. We put the baby up on her chest, and she turns to me and she says, "Why isn't he waking up? Wake him up."
She had no idea.
She knew, but it was so traumatic.
Got it.
She hadn't processed, and she kept asking me to wake her baby up. And I actually, at some point, I remember asking one of my colleagues for their stethoscope. It's not how you diagnose a baby who's died, right? Like, we knew this in advance, but just to give her some like reinforcement, because it had been so overwhelming for her, even though we told her, she couldn't process it. And it was heartbreaking to see her there holding this beautiful baby and saying, "Wake him up. Why is he waking up, Dr. Hope? Why can't you wake my baby up?" And those are powerful events, and we don't talk about them. I mean, how do you go home and share that with, you know, your closest friends and family? And there were people in her family who said, "Oh, you shouldn't have exercised. Oh, it's probably because you didn't take your prenatal vitamins in that first trimester." People say all kinds of really dumb stuff. And so it leads parents not to want to talk about it because there's a lot of shame and a lot of trauma. You know, when she tells that story, there's a lot of trauma around it. And just a lot of blame. Someone in her family said to her, "Oh, it's because you didn't believe in God enough." And she said, like, me and God are having a thing right now. Like, she's faith was really important to her, but she wasn't sure where she stood after having an event like that. And so I think deaths of children especially are really hard to talk about in this culture, and doctors are terrible at it. I will tell you that for sure. But other people are. I mean, you hear that somebody's child dies, and the first thing you think is, "Oh, I don't want to mention it because I don't want to make you think about it." It's, you know, parents are thinking about this already, but we're very nervous in this culture about talking about
I
it.
had forgotten that my kid died. You reminded
Yes.
me. Not how it works.
I mean, I mean, it makes me think of what would it be for Grey's Anatomy to have a central storyline, like where this happens, right? And where there is like bereavement care, and where there's a conversation about cause that like millions of people walk away from saying like, oh, and like opening the door to conversations.
Yeah, and sorry,
Yeah,
sorry,
go ahead.
Jen. I mean, I think storytelling is an incredibly important part of this. I think it's an incredibly important part of everything about reproductive health
And law,
and
right?
law.
Law is storytelling,
Law.
right?
I think it's incredibly important, and it's also important to tell the story right. You know, it can't just be like one offshoot, like one off random thing that happens, because that's not telling the story correctly, right? Like, this does actually happen like 60 times a day.
And is repercussive. It doesn't end in the hospital.
I mean, there's like 60, 65 babies stillborn every day, right? And I would love to see great bereavement care. I mean, I won't lie. I think before this happened to me, if someone told me after stillbirth, like, you should hold the baby, like studies show that holding the baby is beneficial, I would have been like, that is kind of messed up, right? And now I think it's so important. So you would love to see those good portrayals. I'm sure, I'm not gonna lie, I'm a Grey's Anatomy fan too. I'm sure Grace could do it well, to be honest.
But they've chosen not to, right? That's what's kind of, where is it?
Right. So I do think better. At the same time, stories can be a little dangerous though, Thomas,
Flattening.
because well, and then you also get into sort of narratives of like good and bad and the right way to do this. I think it's really important to hold your baby, but guess what? Not everybody wants to, and we shouldn't be forcing it. Right? I think mementos are important, but I love how in the UK the guidelines say make them mementos and put them in a safe. If parents don't want them, they may want them 2 weeks later. Like, we don't have that in our guidelines here. Our bereavement guidelines here are quite inept. So
We don't have national guidelines.
Don't.
How to handle it.
right, and this comes up with the abortion context too. Is like, so for so long we don't want to have the good and the bad abortion, right? The tearful, I didn't want to do this, but like I have some health condition, versus the I just didn't want to be pregnant.
Kind of pitting them against.
Right, we don't want to pit the good and the bad. We don't want to force the correct reaction. Yet at the same time, stories are still so important. But like, how do you balance
We
that?
means we have to be thoughtful about it. Dr. Cohen?
I don't have too much to add. That is beautiful and very thorough.
Thank you. Okay. As we think about stillbirth, how should we be thinking and talking about money?
This one's her.
Principal, I think we have to align on. So maternal health care in general is woefully underfunded. You probably won't find someone who works in a health area or sector that doesn't say something's underfunded. But maternal health care really is underfunded. Most hospitals will admit it's a loss leader for them, that it's, I don't know I'm not an expert in this, but it's expensive to have OB units. And we know that reimbursement rates on the Medicaid side are not high enough, to cover needed services. And,
Can I just add
yeah.
too that like the low payments in Medicaid are part of the reasons for the maternal healthcare deserts that exist in urban areas. That, right, people hear maternal healthcare desert and they think rural or wherever. But because of Medicaid reimbursement rates, there are many physicians who say, I'm capping patients or not willing to take many.
That is 100% right. If we have time, I'm happy to go into details, but you know, I do a lot of research at Mass General Hospital, which is, you know, in the heart of Boston. And Mass General Hospital has prenatal clinics that serve more vulnerable, lower income populations in Chelsea and Revere, and which are not, as the crow flies, very far from the main campus. But even just those few miles, many of the women getting prenatal care at those health centers do not come to, you know, to the city center to get fetal surveillance, for example, which could help prevent a stillbirth. And so a lot of the research that I have been doing is on understanding how to sort of increase access to the screenings that we know can be effective in preventing stillbirth. And for sure, distance is not the only issue there. So just let me see if there's anything else about money that I want to talk about. So reimbursement rates, and that is for commercial insurance as well, are not high enough to incentivize providers. I don't mean individual doctors, because every clinician I've met that I've talked about this problem is not doing this because, you know, is not not doing an ultrasound because they're not, you know, getting the reimbursement. But you know, the system just does not reward high quality care sufficiently, let me put it that way, nor does it pull in innovation, right? Because, you know, innovation in fetal surveillance, for example, will not be highly rewarded in the system. But then there's also the you know, we often focus on Medicaid insurance. It covers almost half of deliveries in the US, and there's a good reason to think about women who are more financially vulnerable. But a lot of women are having pregnancies and deliveries and postpartum experiences with commercial insurance and paying huge amounts out of pocket for care. For example, to take fetal surveillance again, which are the screenings that we do to try to prevent stillbirth and see how the baby's doing, co-insurance rates and copays for that are quite high. They're carved out of like a bundled payment. And, you know, if you are 32 weeks and have gestational diabetes, you're recommended to go in for these tests twice a week, pay co-insurance, copays for those twice a week, not to mention miss work, find childcare for your other kid, you know, so pay for transportation. And the solution is not to not do that, but there are real financial barriers to maternal health care, and we really need to think about payment structures for maternity care.
Yeah, right. And I just think so first of all, just for folks who are like co-insurance, co-insurance, I'm just going to say is similar to a copay, but is not just a flat dollar amount. It's a portion and a percentage of the care often that you are ascribed to pay as a patient, even though you have full coverage. My health law students, I think, are like, I know. But I also want to just reemphasize, like, if it doesn't feel like it's making sense that we're talking about money when we talk about prenatal care, know that if you can't get the screening within the prenatal care, right, the likelihood of a stillbirth is going to increase. Also, the gap in data is going to continue to exist that helps us to fill the gap about what is going on and what to look for. So when we don't pay well through Medicaid, and that is the primary way, right? Most American women, or excuse me, it's like 47%, it's just under, are giving birth through Medicaid. We also know poverty is a problem and an indicator. So this idea of like payment structure that feels far and away, right? In which folks who are in business might say this is not the problem, is deeply connected to it.
Can I just pick up on that? Like getting all the way back to our point earlier about not having data. That's a perfect example. If my co-insurance, meaning the percent I have to pay, let's say my doctor, say it's $200 for me to come in and have a scan. And the percent, some people have to pay 30% of that, or if you have a high deductible plan, you might have to pay all of it. Let's say that's prohibitively high, and I say, you know what, I think I'm fine. Maybe I'll go in once a week, or I'll go in next week, or I can't miss work, right, to go do that. And you have so we spoke a little bit earlier about how a very high proportion of stillbirths have no known cause. If I didn't come in for that screening, then the reason, my risk profile is not documented in my medical chart, and that clinical risk is not there. And then I have an unexplained stillbirth. So when we think about, how we have, a high proportion, we show in this recent paper that something like 40% of stillbirths that happen at 40 weeks have no known clinical risk factor. That doesn't mean they didn't have a clinical risk factor. It could mean that they couldn't access care, which would have detected that.
And if they can't access care, they certainly can't afford an autopsy.
I think it's interesting. We have had lawyers come to our free clinic in Detroit because their co-pays for testing are so high. I mean, this is a high income population, but they can't access care. Because how much does it, you guys have been good at these numbers. If you had to go to the hospital right now, deliver a baby, vaginal delivery, approximately what would your bill be from the hospital? I get that it's going to vary, but give me a ballpark.
$30,000.
I hear 30. Do I hear higher, lower?
I was gonna say 25.
Yeah, I would say probably 20,000, 20 to 25, depending on what part of the country you are, what kind of hospital. It's a lot of money. And so you need to have insurance when you go, and it's a big issue.
And you're getting ready to have a child, which brings other economic pressures that limit,
Exactly.
right?
Yeah.
There's this like idea that because the vision is, I need to economically prepare for X, that you might curtail some spending if you have to make choices.
But what we see is we now are seeing more and more women who are immigrants. In my Detroit clinic, we see this. They don't want to get insurance because they're afraid that's going to affect their green card. That's going to affect immigration status. So they say to us, we're not going to apply for insurance. And the first thing I say is, do you know what it costs to have a baby in this country? Because you can't go to the
Doesn't
hospital.
have to be midwives. That being said.
To add one more thing about the cost, I think of this in a really almost crude way. If you have a preemie who goes to the NICU for several months, that's $1 million, right? That's expensive. So we're very excited for many reasons, including money, about preventing preterm delivery.
Absolutely.
If you have a stillborn baby, what's the cost?
No cost, right?
There is no cost. So one of the things I've been interested in my own work is thinking, how do we document the cost for families after this happened? Because it's not zero, but you can't quantify it as easily as when you've got a baby racking up a $3,000 bill every single day they're in the NICU.
It's very tangible.
Yeah, so how do you think about mental health costs, lost work costs, funeral costs, other things that might be costly? Because that's what people care about, it's money. And if we can show that stillbirths have a cost, then people are more interested in preventing them just from a very sort of crude financial.
So thank you. I have one other question, but we'll see if there's time for it. I want to open up the floor to questions from our audience. Gabby?
Thank you all for being here. I want to thank you for bringing up the case of Brittany Watts, because this is something I've been thinking about a lot. For people who, I think some of us might know that this is happening increasingly across the country, but people who are experiencing miscarriages and stillbirths, often at home, because it's, unplanned, are going to doctors following the pregnancy loss, not really knowing what to do. Sometimes they wrap the fetus in a blanket. Sometimes they put it in their closet. Sometimes they miscarry into the toilet. That's very common. And then they go to doctors, and doctors treat this as someone who has killed their child, and they report them to the police, and the police will charge them sometimes with murder, oftentimes with violations of what are known as fetal remains laws. So desecration of a corpse, abuse of a corpse. It's a growing trend. It's particularly bad post-Dobbs, but it was happening pre-Dobbs. And you feel like a really great panel to answer the question, because it's this intersection of law and medicine, and how and where
and criminal law.
And criminal, exactly, like how all of these areas intersect. And it also speaks to like the behaviors and the decisions that go into like, how do you decide to call the police and bring in the criminal component when something like this happens? And it strikes me as a really intractable problem, in part because we don't talk about miscarriage and stillbirth. And there's something, the attorneys who've worked on this, who I spoke to, they talk about something, they call it the ick factor, like that people who criminalize this, they're like, ew, I don't want to talk about that gross thing that happened to you. And that feels like it's a really big component. And so I'm curious to hear from you all, like, how do we get at this? Because it's only getting bigger. And I think to your point, like Black women and the people who are already so heavily criminalized are squarely in the crosshairs of this trend.
And Gabby, I would point folks to the writing of Kiara Bridges, yes, who's thought about this, of Wendy Bach at the University of Tennessee, who's thought about this and the criminalization of pregnancy. There's a really, I sent this to the panelists, but kind of drew it back because I was like, oh, this is miscarriage, not stillbirth. There's an episode of Criminal recently about the story of a woman who actually the police see on Facebook her grief, and then decide that a 5-month stillbirth, that she at least believes she caused, was actually murder. So I think you're right, and I'll open it up.
Well, I was just nodding your whole question. By the way, I have lots of thoughts on this, some of which is in the book and some of which is not. I think one big reason this is happening is that no one realizes how common miscarriage and stillbirth is. Right, especially when someone's having a stillborn baby at home, and then they tell the cops, no, the baby was stillborn. What's the immediate reaction? No, it wasn't. You're lying. You killed it. Because no one knows. No, actually, babies do die at 37 weeks. Right? Actually, it happened 60 times today. Was each of those 60 a crime? Right? Was each of those 60 actually murdering a baby? Right? So like, we don't have the broader perspective of actually how common this is. I think it's also super problematic. The ideas, and this kind of gets back to the right and wrong that I mentioned with storytelling, seems like there's a right way to do this and there's a wrong way to do this, right? And you better show those right emotions, which is also very funny to me because there's been some work within the stillbirth parents that if you too much acknowledge your stillborn baby, you are also a little crazy. Right? Like, oh, you want to talk about your kid? Like, oh, your kid has a stocking up at Christmas? Like, you're a little bit off. Right? So actually, if you grieve too much, that's also the wrong way. But if you don't grieve enough, that's also the wrong way. Right? So, and I think there's just no comprehension of like, you do realize this is like a shocking physical thing. right?
To the person, not to you, right?
To the pregnant person, sorry, right? Like I mean, I think about 50 years of being told I had a choice and control over my body. And then I think about all the things my body did with pregnancy that I had zero control over, even though I was told for decades that I had choice and control.
And responsibility.
Right? I think also this is about, oh my gosh, gross, you had a miscarriage on the toilet. You do realize that happens all the time. Also, where else am I supposed to have a miscarriage? Where do you go when your stomach hurts, y'all? So I just think there's so much disconnect between the realities of pregnancy loss. I mean, I guess I should also say, of course, like you can't talk about this, obviously, and Thomas already brought this up, without talking about the income and racial disparities of who's getting arrested. You know, I think about the right way and wrong way, and sometimes I wonder if a Black woman even has the capacity to do it the right way, right? If she would ever be judged as having the correct grief, right? So I mean, in short, I don't think this is just a change the law solution. This is we need to learn societally and culturally a lot more about pregnancy loss. Right? I just don't, if people really understood that there's like 60 stillborn babies a day, and there's 1 million miscarriages a year, at least, probably more. Right, so 1 million miscarriages and 20,000 plus stillbirths a year. Really? Each of those is a crime? Oh my gosh, cops are going to be busy.
Well, I mean, can I also just draw in forensic science? I mean, I think about Aziza's piece, Floating Lungs.
Yeah.
And there's this added piece. So forensic science has been wrong for lots of reasons for a long time, from arson kind of science to even some of the stuff around like tire tracks when there's a crash. But there's like when you have this additional void, it feels like you get to fill that vacuum however you would like. Dr. Bull, Dr. Cohen.
I was just gonna add, I've been thinking, I sat in an autopsy this week for a baby who died suddenly, which is a really hard thing to do. And you may or may not know that if a baby dies suddenly at home, the police automatically get involved, and they come to the house and they say, here's a doll. I want you to show me how you put the baby down. I want you to show me how you found the baby. And so they make you like go through this whole process with the baby. Then CPS comes to your house and they're like, you have another kid. We're kind of worried. We are going to come monthly until this autopsy is done. So you have parents who are grieving tremendously. There is some role of protecting other children in the house if something was done, you know, if there was inadequate care, but you've also complicated the grief. And I think it's the same process when you're talking about criminalizing people who had a baby die inside of them before it was born, right? Like, it's the same thing. You are just making that grief so much more dramatic.
Sorry, I have to add 2 more things. I have way too many thoughts about this. I mean, one thing that also cracks me up, not like haha cracks me up, but like so much of the reaction after stillbirth is just like a shrug. This happens. But then we think we can prove beyond a reasonable doubt that someone's conduct caused this stillbirth. Like, what? How can those 2 things coexist? And I think one really, really important part also that the criminalization debates, well, one thing I want to add that I can add to that is I'm also so concerned about the treatment medically one is getting when they are giving birth to their stillborn baby, when they are also being suspected, excuse me. There's a woman in Florida who was arrested, Adora Perez, and she doesn't have a picture of her baby. Right, no mementos. She doesn't have a picture of her baby, and she feels guilty that she might forget what he looks like, and it's just it's awful. There's no why didn't they take a picture of her son for her? Right, so it's not just the trauma of like, I mean, there's so many traumas, right? There's self-blame is so prevalent after stillbirth, and now you have the state telling you, yes, this is your fault. So not only did I already think it was my fault, now the state's telling me it's my fault. And then there's the trauma of like, how were doctors treating you? How like were the providers treating you? Because again, this is probably a judgy healthcare provider in the corner who called the cops. And if they called the cops, they probably also weren't giving you the type of bereavement care that I think all stillbirth parents deserve.
And I wonder if they're giving you the prenatal care.
I mean, yes.
Okay.
I have lots I could add, but I just want to hear.
I think it also gets really hard. I'm just thinking personally, I'm caring for a patient right now who's using cocaine actively. And of all the drugs that are out there, cocaine worries me because cocaine causes your blood vessels to constrict, which cuts off blood supply to lots of things, your heart, your brain, a baby. And so I think about it as like a drug that kills babies because you can use cocaine, your blood vessels constrict, and boom, things can go downhill. And so I really struggle personally with, I don't want this baby to die. Like, this is a really high risk baby. And with this mom, I'm just like, okay, can we deliver her? Can we deliver her? Like, I just want to get her delivered before something bad happens. And I would really like her to get treatment, but she's not going to get treatment. And I think you talk about this in your book too. Like, we can't be going around judging people for, you know.
That's not the solution.
That's not the solution. It doesn't fix anything. My goal is to get this baby out alive, but her last baby didn't come out alive because of the cocaine.
Well, and I just also want to just raise the name of Professor Dorothy Roberts in terms of also the after effects, which we haven't talked too much about, but Dorothy Roberts talks about, she has a great book called Shattered Bonds about the child welfare system or family surveillance system, and the ways in which when we think about stillbirth, we also have to think about, right, who then is impacted on the back end, including those other children who may be removed from homes. I hope that's like the last dark thing I say. I'm sure there are other questions, but I really invite you to be in conversation, certainly with me and the other health law professors here at WCL if you're a student, and Professor Fields, who is here from wonderful Hustle, Howard University School of Law. But I want to wrap up maybe with looking towards the future and looking towards possibility. And we have about 5 minutes to get there. So Jill, it's really clear from your book that there are really actionable ways to reduce the risk of stillbirth that are legitimately low-hanging fruit, that don't require a lot. Can each of you say more about what we have seen work to reduce rates of stillbirth, like abroad or domestically, to give the audience a picture of what those low-hanging fruit are so that maybe they can go out and either advocate them or raise them in conversation with the folks who are important to them, who are pregnant and expecting?
Can we make the doctor? Please.
There are a lot of things. I guess I think about, especially, 98, 99% of stillbirths happen in low and middle income countries around the world. So even though we are all here talking about stillbirth from a US perspective, it is much worse in other countries, some of the countries in sub-Saharan Africa, where we have both worked. It's a tough problem. One of the most basic things is to get someone into care early so we can figure out what their due date is. Because the longer you stay pregnant after your due date, the higher your risk of stillbirth is. And if you don't come into care till you're 32 weeks, our ability to predict your due date is not nearly as good as if we see you in the first trimester. That's just how ultrasound is. So if we can get people in early and know when that baby is going to be fully cooked and ready to get out, that's going to drop risk. And that's really important. I think a second thing is access to care. And we see this, I see this all the time in my Detroit clinic. It's not just transportation and copays and insurance. It's that people say, I went to the doctor and she didn't listen to me. I told her I was worried about this and she didn't listen to me. And trust is a big issue for a lot of people. Thinking about concerns about immigration. I think we're going to see more people delivering at home because they're going to come to free clinics like mine and get their prenatal care. And then when it's time to have a baby, they're going to go home because they don't have $20,000 or $30,000. And people are delivering at home from all different risk levels. That's more dead moms and dead babies. And so I think getting people into care, getting access to care. And I think the third thing is I spend a lot of time when I care for women during pregnancy talking to them about, if you're worried about something, I want you to call me. I don't want you to sit at home and think, I don't want to bug her, I don't want to bother her. I want you to call, because I think that's part of the trust, and that's part of like getting people alert to come check it out. I want to hear what you're saying, and maybe everything is great and we can reassure you and send you home, but I want you to tell me. So those are the things I just kind of think about off the top of my head.
Wonderful. I mean, I wonder, Jill or Dr. Cohen, if you want to talk about safe baby bundles or any of the things that kind of come up in the book.
There are other countries they call them safer baby bundles, and have they have different standards of care than we do. And
Across women's health, right? Sorry to interrupt. I keep interrupting you, but yeah, sorry.
it's all right. I want you to interrupt. There are components of that care that we just don't do as much here. And, I'm not going to pretend that I'm smart enough to talk about the things we do for fetal growth restriction versus England and what Australia does. I mean, I just want to echo one thing that is very much in the Safer Baby Bundle zone. It's exactly what Katie just said too, is if you have an issue or you think you have an issue, call the midwife, right? And there's bigger pamphlets like, you're not bothering us, like, please just call. Right. And we just have a different perspective, I think, here.
A different economic model, maybe.
Yeah, we do. Yes. And we have different kinds of providers, let's be honest too, right? But I dislike, I so do not want solutions to be empowering the pregnant person, right? Because different pregnant people have different abilities to exercise their power, right? But it part of me always like, oh, I don't want to bother to the doctor. It's their job. It's usually what I come back with. And, you know, you are the expert, right? If you are pregnant, you are the expert, right? No one can know better than you, right? You, especially now that a lot of times we'll rotate care among OBs, like you are the only constant with that baby. So hopefully we all have OBs like Katie that will say, no, I really do want you to call me. Okay.
I agree with pretty much everything they said. And I really like that you brought us back also to the global perspective on stillbirth. To be able to say that, you know, I've done a number of studies in East Africa where we follow women longitudinally, as we say, like from pregnancy through delivery and postpartum, thousands and thousands of them. And we regularly see something like 5% perinatal mortality rate, which means third trimester stillbirth or an early newborn death. And that is still what we're seeing even in capital cities like Nairobi. And really, in my opinion, like the biggest issue there and the lowest hanging fruit is access to C-section and just access to emergency care and labor. A big part of the stillbirth burden in those settings is intrapartum stillbirth, which are, you know, stillbirths that happen because you don't have access to C-section or assisted labor quickly enough. But we're also probably going to see increases in rates of stillbirth from low-hanging fruit like malaria, for example, where declines in global aid to support simple things like sleeping under an insecticide-treated mosquito net, which was sort of the focus of my early research to prevent stillbirth. There's big declines in funding for malaria, HIV, and other things that we know are on the pathway to stillbirth and other adverse outcomes. So the agenda is somewhat different, but a lot of it is about access to care. I really like this point about listening to pregnant women. And I want to think about that more than just sort of an ethical obligation or, you know, instrumental to something, but really think about actually how systems can be designed to elevate women's voices and have their experiences of pregnancy and postpartum. Actually, this comes in a lot in my work on postpartum care, is listening to, but systems that sort of make it the default that we sort of, what I was thinking when you were saying that is that I think there is for a very good reason, a very dominant narrative that we over intervene in pregnancy. And that is very, very true in a lot of cases. But I think it also causes us to miss the fact that we really under intervene in a lot of other settings. And it's a typical health economics decision science problem of like, who should get this care and who shouldn't. And I think that'll lead me to my final point, which is the technology needs to get better, right? So we have technologies that we know can be effective in certain scenarios, and we need to increase access to them, but also the technology is really bad. Like we have devices that monitor our sleep quality that are more precise than ultrasounds at getting at babies' weights, right? And there are a lot of root causes for that, which we probably don't have time to go into, but one of them is just like a cynicism, I think, and like a lack of aspirational thinking about how much better we could be at knowing whether, you know, at this not coming out of the blue, right? Like it doesn't have to necessarily be the case that we don't know how the baby is doing in there. And so I do think that there is more aspiration needed, and you know, moonshots in technology for
And
health.
yeah, right. And I think I'll just say, first of all, thank you. I'm going to close this out and bring Professor Shelzo up. That also like the techniques to live aside like basic things like excess.
Yeah.
Like one doesn't solve for the other, they have to live in combination. I want to thank you for just such a profound conversation, for your time, for your energy to connect with this audience and our students, and actually to travel here amid all these flight disruptions. And so audience, please continue to be a part of the conversation and thinking about that. And with that, I'll turn it back over to Professor Shelzo.
Of course, thank you.
Okay, well, first of all, listen, we do a lot of programs here, but I have to say this has been extremely powerful, impactful, illuminating. I don't think anyone has moved an inch because of wanting to hear your expertise, your insights, and as you said, the stories and your storytelling. Thank you for sharing this with us today. And I think we've reached a national audience, which is also a fantastic goal we have at our program. And we have had an extremely engaged Zoom with a lot of questions and comments. And so I'm going to invite them, because they're still hopefully listening, to reach out. We are going to follow up with not only the recording, but also contact information. I know there's more folks who want to have maybe address some more questions. They want to share their stories. I hope that they can reach out to you, because I think this is going to really be a wonderful just invitation to start more and more conversations, to raise awareness. And I think it was really a home run that you really delivered the message, and we thank you for that. So again, please, let's thank these wonderful. A couple of other notes, as I said, this is being recorded, which we'll share with everybody. We have a little bit, some more programming. So let me just put it on your radar screen. Again, there's Future of Healthcare series, as you can see, is very impactful and powerful. We're going to continue with a great program in February, and that's going to be virtual. And it's going to be After Dobbs, celebrating the book by David Cohen and Carol Jaffe, After Dobbs, How the Supreme Court Ended Roe But Not Abortion. So this is going to be a really important conversation. Please join us in the early winter, early spring. We also have a wonderful Health on Policy student-led brief, which a lot of, I know the students here are leaders in that brief. And you are putting together a wonderful program that we at the Health on Policy program are going to support. And that is going to be revolutionizing drug development, the impact of AI in pharmaceuticals. So as you can see, we cover a lot of exciting topics here at the Health Law program, and we're really excited about our student leaders. And their program is going to be on March 4th, and that'll be in person and Zoom. So just a couple of things to look out for this spring. So just again, I want to thank Tamina for our, amazing organization here. Maya, our faculty director, not only just amazing guys. Again, our panelists, Thomas, thank you. You are just so skilled at really elevating and highlighting the important nuggets that really make the program powerful. So thank you for that. We also want to thank the Gender Theory Law Practice Program here at AU, a very strong program, and they are very helpful to support this program, as well as the American Health Law Association and the American Society of Law, Medicine, and Ethics. Again, just wonderful partners, educational organizations, nonpartisan, nonprofit, all with the same mission to advance education. So thank you for being part of our program today, and we wish you a wonderful afternoon. I hope you'll enjoy some more lunch, coffee, and dessert. Thank you.